Hello, everybody, and welcome to this episode of Macro Pro and Friends webinar series. We are doing the University of Macro Pro. I'm Diane Cohen, the Dean of Education at Macro Pro and Vice President, and I am joined with Dr. Gus. Can you tell us, Doctor, what your expertise is? Where'd you go to school, etc.?
Okay, well, a little bit of background before we begin my presentation. So I'm a local Californian who went to Davis for undergrad and then St. Louis University for medical school. And then I trained in physical medicine and rehabilitation at the University of Texas Health Sciences Center in San Antonio. And then I did another fellowship in occupational and environmental medicine at the University of California, San Francisco. And then I decided to take a test and become board certified in pain medicine. And so since that time, I've been worked in an outpatient clinical setting with a physiatrist in the South San Francisco Bay Area named Sunita Jayakar, and learned quite a bit from her, and then did on-site work at Intel Corporation. Subsequently was the medical director for the city of San Jose, where I worked a lot with utilization review, case management, closely with the adjusters, and did kind of similar work, but not quite as extensive occupational health work at Safeway and Albertsons as their medical director for risk management. And that was a national role for a while, but primarily California. And then more recently, kind of gotten back into patient care. I'm working in a private practice with Steve Feinberg in Palo Alto, and doing medical legal evaluations. And also, I'm the medical director at Employee Health Services for UCSF Benioff Children's Hospital in Oakland. And I work at San Francisco General as well, kind of help working with the residents a little bit in occupational medicine.
And of course, here you are helping out the workers' comp arena. We are very lucky to have somebody with all these qualifications be part of our system. Now, Doctor, I'm certain there are going to be people on this webinar today, like myself, that we're not involved with claimants, or maybe we are, but maybe we don't have any claimants with this brain fog issue.
Uh-huh.
So I'm wondering if you're going to clear up for some of us what the difference is between brain fog and early onset dementia. You know, what about forgetfulness? And are we just too busy sometimes so we forget things? How do we know if we're going to be that person that ends up with a really serious memory problem? And the word I'm looking for is dementia. So you see, I have it right here. Is it because I'm too busy? Because honest to God, I'm really crazy busy.
But I'm going to also qualify myself a little bit because I'm not a dementia type doctor. I primarily in workers' comp stuff, and hopefully there's not too much dementia that's work related. But I do have familiarity with some of the issues that kind of intertwine between dementia and some of these issues and memory loss, et cetera, confusion. And I think that in terms of when to worry and when not to worry, I think we can certainly get into that a little bit, because I think that's really a huge part of what happens in the workers' compensation system when individuals have these kinds of symptoms and the concern that they have.
Yeah,
And
and
I
I
think
imagine
that's
their families probably bring it up. It seems to me like this person's no longer doing this, and they seem to forget. So I think the families of the injured workers are probably bringing up some of these issues too.
yes. And it's heightened awareness, but we'll talk about that a little bit later too, in terms of what happens when you have that individual with their family members and how do you navigate that. Particularly when you're not a psychologist or a neurologist, but you're, frontline person dealing with this and not always having access to specialists that deal with dementia and on a regular basis. And what are the things that you can do to kind of help navigate the system, and kind of, when should the alarm bells go off, and when can you try to, manage things conservatively and hopefully direct or intervene to make a difference, because these are very challenging situations to address, not just from the medical standpoint, which is probably the least hard about it. It's all the other factors that are involved, when you're talking about workplace issues, injury issues, compensation issues, it's very challenging. And and I'm hoping that people have questions to
Yeah,
kind of address it for things that I can't bring up in the chat, because um, this topic, at least for me, is one where I don't come with authority in terms of being the most knowledgeable person. However, I have an approach. And I think that's what we kind of have to look and see, particularly when we're reading medical records, etc. How are these problems being approached? When do we need to, be a little bit more aggressive? When can we set back? What do we need to watch? And
all
hopefully
right,
that's what the audience can kind of ask for. And if I don't hit those item topics as well as people like, please call me on it, and I'll try to address it, because I think that's the most interesting part of this, because these are one of those conditions where the best answer for most questions is I don't know.
got it.
And so
So
the go
let me
ahead.
do a little bit of housekeeping real quick, and
Sure.
then I'm going to read a comment that you could possibly weave into your presentation.
Sure.
So everybody, today's event is worth one CEU credit. It will be emailed to you as long as you're logged on to the GoToWebinar platform. You will receive your certificate within 1 hour. If you don't get your certificate, you must let me know pretty much immediately. I can only help you with that for 30 days, and after 30 days, I cannot assist you anymore. There are handouts. Please download them from Doctor's presentation so that you have it. Again, if you have any questions, please go to the question box so that we can ask Doctor these questions, and I will be monitoring those for you. And then if you want to see this again, you can see it on the Macro Pro YouTube channel. Now, I'm going to start with this comment. You can either use it now or
Okay.
somewhere in the presentation. Um, there's Angelique is saying that make no mistake, there are COVID claims out there where people suffer every brain fog years later after exposure from workers' comp. So I think that's true. And Doctor, you and I did a presentation webinar on COVID many years ago. So if you would
Yes.
keep that question in the back or
Oh,
that comment in the back,
absolutely.
that'd be fantastic. And if you could address it. All right,
Okay.
the floor is yours.
Absolutely. Okay, so thank you all for attending today. We're going to be talking about brain fog, as we mentioned, and I'm going to talk to you about it, professionally, not just because I personally experience it every once in a while. And we can hopefully hit on some topics, and please feel free to kind of ask and chat and interrupt, because I think that's what the most valuable part of this topic is how to navigate it, how to approach it. Because as I said earlier, most of the most interesting questions, probably the best answer is I don't know. And we have to understand that. But there are certain interventions that can make a difference for people. And the challenge with addressing this particular topic is trying to distinguish about what things will make a difference and help things move along. And if a lot of you are claims administrators, how do you get to the end? And what kind of things can make a difference? And, when do we want to, do a full court press, or when can we kind of step back? So please feel free to intervene when you can, or ask questions when you can. So, let me think. So, disclaimer, I don't have any identified conflicts of interest, and I will, acknowledge that I did use artificial intelligence in developing this presentation, and with a little bit of natural intelligence, but we'll see if that pans out. So, what is brain fog? And I think this stole this graphic from Cleveland Clinic, but I think it kind of expresses things quite well and kind of explains the problem with it. Number one, we have people that, difficulty concentrating, focusing, confusion, being tired, mentally and physically. We kind of lose where we are. Sometimes we forget our keys. We can't remember the right words, word choosing difficulties. And sometimes we're not able to process things quite as well. Maybe the topic's really complicated, or maybe we're just a little bit slower that day. And sometimes there's lack of concentration. So a lot of these things, we've probably all experienced. And the difference between kind of what we've experienced and some of the people that are coming in to get help are the symptoms seem to stick around a little bit longer. And that's concerning. And that's what we're trying to address today because, it's easy to kind of dismiss these as the normal stuff, but the problem is it happens. And the bigger issue too is it really happening more than it was normally, or are we just paying more attention to it? And those are some of the challenges as a clinician. And sometimes when you're just trying to read the medical record, trying to figure out what's going on. So we'll try to address that a little bit later in today's presentation. So how do you diagnose brain fog? Is there a specific test? No. Is there a blood test? No. Is there an imaging study? No. There might be some future things, what they call functional MRIs, but right now it's basically a clinical diagnosis, and it's one of those things where I kind of think that, yeah, I know it when I see it, and I kind of know when it's severe, but I can't tell you why or what the differences are. And hopefully this cartoon kind of explains that a little bit. Yeah. So I stole this card from Les Courtet, who's a prominent neuropsychologist in the workers' comp arena. We did a presentation together on this topic at the American Occupational Health Conference in 2025. And I really like it because not only did he focus on the symptoms, but he also focused on kind of where's the problem. And so he kind of broke it down in terms of when people have complaints, is it something that's intermittent, comes and goes? Is it something that persists or is sustained? Or is it something in terms of where it's kind of like it's a little bit more difficult to process, either because there's too much information, the information's complicated, or perhaps there's something else going on. So as you can see, there's a lot of overlap with some of these symptoms as well in terms of what can be responsible for this. And some of the highlights are, if you notice, mental fatigue or mental exhaustion. It could be a processing issue. It could also be a little bit more in terms of being able to pay attention to something, or you have to pay attention a little bit more closely than you normally would. Concentration, which make it a little bit more difficult. Or is it just being intermittently forgetful? And you just have a little bit of difficulty concentrating or focusing, and then trying to distinguish between these symptoms, between what is something going wrong, or is there some type of incident or some type of a trigger. And that's really the biggest challenge for this kind of a problem. As I kind of alluded to, really what I want people to take away is the approach and understand what a clinician, someone who's not necessarily a mental health specialist, but commonly seeing these kinds of problems, what they're facing, how do they do an assessment, and hopefully kind of give you a little bit of insight about what probably should be done or what may be done. And kind of discuss some of the issues in the system that kind of make it difficult to handle this. And one of the problems is we'll talk about is time. But during the initial encounter, how does the person assess this individual? One of the things that's real important, and I'll allude to a little bit later, is getting detailed information, getting specifics, not someone just saying, oh, I have brain fog, and the clinician nodding, I know exactly what you mean, but really kind of drilling down in terms of what are you forgetting, when are you forgetting, or what kind of things are you having difficulty with? All of these, and then trying to address how it impacts their lives and develop workaround strategies. And the problem with that is, for a clinician, it takes a lot of time to do that. But that's part of the initial assessment in terms of trying to figure out what's going on. And the problem is, if someone has a history of COVID, they haven't been admitted into the intensive care unit, they don't have any lung problems or breathing problems, but they have this particular issue that is non-specific and there's no diagnostic test, there's no way to verify it. How do you handle this? Same thing with a head contusion. When someone hits their noggin, there's not really a concussion. They don't meet diagnostic criteria for a concussion, but they present with these kinds of symptoms. How do you handle this at the initial assessment? So sometimes things get better with time. People's backs get better. People's, legs get better. It's just a matter of waiting for things to get better. Most people recover. In workers' compensation, we might have a little bit of a different opinion about that because we don't see everyone that gets better. The only people that get our attention are the ones that don't. But in general, the information is that most people get better, and that's something that we can tell the patients initially. Or does a red flag go off in terms of this might be a little bit more than that? How do we try to direct and get an early specialty assessment? Do we need to get a psychologist engaged right away or a neurologist engaged right away? And at least in the California workers' compensation system, they're relatively rare and hard to find and hard to get scheduled with quickly. So you need to kind of determine whether you want to get that rolling sooner than later. My inclination is if I have a little bit of concern about what's going on, I tend to make a referral a little bit earlier, knowing that it will take a long time to find somebody, knowing that it'll take a long time to schedule somebody, and then understanding that I can also withdraw that referral if the people get better. But there are some concerns that I have sometimes with this specialty referrals in terms of medicalization of what's going on. The other issue is sometimes the red flag goes off. Do you need to validate these symptoms in terms of, not whether these are, there are a lot of situations where these symptoms are present. The issue is what is the cause of the symptoms? How do you sort it out? Versus these symptoms don't seem to align very well with what happened, with the degree of disability these people describe. Do we need to maybe think about getting validation testing a little bit sooner than later because things don't add up? The severity of the problem reported is greater than it's supposed to be. The mechanism of injury doesn't fit. So maybe we need to find out what validation testing can help. What does validation testing do? Does it tell you whether someone's lying? No, it doesn't. What it does tell you, though, is whether they have consistent or inconsistent responses. And if someone is consistently providing a wrong answer in order to emphasize how ill or the difficulties that they're having, that in and of itself tells you that this individual has the cognition and the strength to be able to deliberately provide the wrong answer more than the right answer. So, you know, remember that when you're asking for validation testing, what it's actually testing and what it's looking for. It's looking for that inconsistency or the probability of getting something wrong or right. So if you're confused, should be closer to 50-50, rather than completely wrong or completely right. And feel free to put questions in the chat anytime you want to, and I'm more than happy to address it right then and there while it's fresh on your mind. As I mentioned, in terms of the early specialty assessment, psychologists are not that easy to come across. It's more about the assessment in terms of determining what can you do, and then also addressing some of the interventions. Now, with some familiarity with head injury, and I'm talking about a little bit more severe head injury where there's not really a question about the mechanism of injury, there's not really a question about what happened, and even with our stroke patients, speech therapy. And I know that psychologists have said that they're not as appropriate for the assessment of these kinds of neurocognitive disorders, and that's probably correct. But from an intervention standpoint, when people do have significant difficulties with memory and processing, they have some very practical tools. And typically we see them used with minor head injuries and stroke patients where there's, memory books. We write down things as soon as they happen so you don't forget. You have certain triggers that you can use to prompt you to do things. In today's world with reminders in our cell phone, it's even easier, because people have issues with, back in the day with gas ovens, leaving the stove on, leaving cooking something and forgetting about it. Significant mental health issues. Those are things that the speech therapist can help with and work with an individual to kind of be able to navigate the difficulties of it. But those aren't the typical people that come into our office in a workers' compensation setting, when they come in a week or 2 weeks later and it's not a clear-cut clinical presentation. What else can that individual do? Are there risk factors and comorbidities that can be addressed that may help with this? But the problem is within the workers' compensation system, some of these comorbidities really have nothing to do with the injury itself. So with diabetes, and I know that we have the analogy in terms of when we get surgery done, we need to correct it, and there's a temporary period of fixing it. But in this context, how is that addressed? It's not as clearly related to this problem as well. And with the COVID, when there's not really anything to do at this stage to treat pathology or pathophysiology, how do you handle it? And fortunately and unfortunately, a lot of the interventions are the same. The problem is that since they're kind of simplistic, not everyone takes them seriously because they feel that their symptoms are not validated and you're not hearing them. And that's a significant problem when you're a frontline clinician in workers' compensation who's quote unquote paid by the insurance company or working for the employer. There's a certain element of distrust that you also have to address when you're trying to explain the symptoms to people. So, what is brain fog kind of linked to? Some of the things kind of seem self-evident and obvious. Lack of sleep. All of us have experienced lack of sleep in general, and we know how it impacts us. So it's very easy to relate this particular problem to the symptoms people understand. And and lack of sleep, is not something that's self-evident and obvious to a lot of the people experiencing these things. And they think that the lack of sleep is a symptom of it as opposed to a cause of it. So that's something that needs to be addressed as well. Stress. Once again, I know what it is, but I don't know how to measure it. I don't know how to really describe it. But usually when I think of stress, I think it's, not being in control. And an example I have is like firefighters who run into a burning building, to which most of us find very stressful, but to them, they're trained in doing that and they know exactly what they're doing. So they're very comfortable and happy to do that. But doing the paperwork afterwards, it's a little bit different. That's stressful. So to me, I look at stress in terms of the degree of control that you have of a situation. And a lot of us kind of experience that lack of control and the lack of a means to handle it. And we also talk about coping, and coping is a way of managing stress as well. Autoimmune conditions, rheumatoid arthritis, all of these other issues, but that are kind of linked also to pain, lack of sleep, etc. Same thing with diabetes. If the blood sugar is poorly controlled, is there an issue in terms of the brain not working quite as well? Yes, there is. Other mental health conditions, which is a strong relationship in terms of what do these people bring to the table. And frankly, for me, I'm very engaged in delayed recovery and the causes of delayed recovery and anxiety in terms of coping and situational anxiety. That's very big in terms of contributing to these kinds of problems, but also just to almost any medical condition we treat within the workers' compensation system. When there is that lack of control, the lack of knowledge, and trying to deal with this difficult system to navigate, how do we address that? Neurodivergent conditions, a term I'm becoming a little bit more familiar with, but in general I think it kind of refers to individuals with autism, and there's degrees and on the spectrum, and certainly that can play a role as well. Hormonal changes have been mentioned, particularly perimenopausal. In terms of estrogen or the decreasing estrogen levels, they haven't really, in terms of at least the literature I saw, didn't really show a strong correlation with that, even though individuals kind of experience it. It's, they haven't been able to show it. And, measuring hormones is very challenging, especially in terms of trying to establish normal reference levels, et cetera. So,
Doctor?
guess ahead.
So a question for you as you go
Sure.
through these,
Mhm.
how can we tell whether or not an injured worker, really has these symptoms or it's something that he is feigning? Because I'm sure this is something that, the claims examiners listening today have to deal with.
So that's kind of what we're talking about in terms of doing the early intervention in terms of validity testing. So, things have to fit. So if someone has COVID, they have long, severe, critical illness, they're in the intensive care unit, oxygenation is poor, they're expected to have some kind of lack of sleep. It's a little bit easier to say, yeah, they're having these kinds of problems. Interventions roughly are kind of the same, but you might be able to help by supplemental oxygen, by improving the treatment for the respiratory problem. Same thing with like a concussion. If someone has a concussion where they have post-traumatic amnesia, and most people get better with concussions, but they do have that peri-injury confusion, etc. Um, those are the things that I look at. It's and that's not what everyone looks at. I look at the mechanism of injury. If does the mechanism of injury fit? As you'll see later, the risk factors for developing this are not necessarily related to the severity of the injury, however. It's more related to other issues that are more psychosocial, and that's why the interventions are primarily psychosocial and education. But the key is, like I said at the beginning of the talk, is I don't know is probably the best answer for a lot of these things, but we do have a little bit of intuition. We have a little bit of sense of what's going on. And what I always like to refer to is if you can get additional information. Back in the day, there was a talk radio show that I used to listen to. His name was Paul Harvey, and he would talk about, common occurrences that we'd heard of and stories that we all were familiar with, but there'd always be a backstory that kind of helped explain what happened, why it happened. And he would say, and now that's the rest of the story. And I think that plays a big role in a lot of these. What's happening in the workplace? I'll get into this a little bit later. Are there other issues? The standard stuff. What's going on at home? Is there a diagnosis of cancer? Are they being a caretaker? All these other things that you kind of recognize as risk factors for these kinds of things. And it's not that people are faking per se, it's more that they're relating their symptoms to this and not to what the more likely source of it is. And the issue is kind of navigating that and seeing what we can do to humanely help people go through the process and giving the appropriate help that we can, but at the same time, understanding that when we've done all we can, there's something called maximal medical improvement, and that's something that we have to remember as well as clinicians, and we tend to forget. Hopefully that kind of addresses anybody's questions, and I'm more than happy to kind of spend more time to addressing a specific question. Other conditions that make a big difference are chemotherapy. Chemotherapy, definitely individuals that experience different, particularly specific chemicals, have a legitimate physiologic or pharmacologic explanation for it. There is certain type of neuronal damage, nerve damage. That one's not that difficult to understand. But you tie the fact in that these people are, involved in a situation where they don't have any control. It is highly stressful as well. And the issue is trying to sort out those two. So that means just because it makes sense that they have this problem doesn't mean we stop and don't try to provide the interventions that can make make a definite difference to reduce the intensity of these symptoms, if not eliminate them completely. Any questions in chat? Okay, next one. So I looked at a couple studies in terms of, how do we predict who's going to have cognitive symptoms? And it was a broader term than just brain fog. Fatigue was probably the number one problem that people listed, but brain fog was a close second, and it aligned with poor concentration, memory recall issues, etc. And so, and part of the thing that you're going to see is it's not really a whole lot of people involved in these studies. One at the University of Washington was about 89 people, and there were about 530 people at Cornell. And at least the individuals walking into my office with these kinds of symptoms weren't hospitalized. These individuals were hospitalized with the primary diagnosis of COVID. It wasn't coincidental when they were screening that they also had COVID. That's why they were in the hospital. They were severe enough that they required nursing, probably oxygen, medications, etc. So, with all of that being said, what were the risk factors? Pre-existing anxiety and depression. Kind of goes back to the similar risk factors that people have for low back pain that doesn't get better, plantar fasciitis pain where it causes significant disability. Other ones were sociodemographic features, which I don't personally take too much credence from based upon the small numbers, but female gender or sex was considered one, Hispanic descent, or lower socioeconomic status. Now, theoretically, these are all independent risk factors, meaning that independently, irrespective of whether, you're in a group that might tend to be a lower socioeconomic status. Theoretically, these are kind of separated a little bit because, to me, the most obvious one is lower socioeconomic status, where if you're hospitalized with COVID, you're not working, and you don't have financial resources, the stress component is there, self-evident and obvious. And I don't know how you kind of distinguish or separate those out. Um, high blood pressure, diabetes, high cholesterol, I think, which ties in more with the healthy behaviors we'll kind of talk about. Same thing with the poor diet. Inadequate sleep is probably kind of tied in and very significant. And alcohol and tobacco use, because alcohol interferes with sleep, so can tobacco. Plus, they have their own independent risk factors and other issues in terms of of how much they're used. And these are not always things that we can easily address in the workers' compensation system. And the other ones that, obviously brain injury or a concussion, certain medications can certainly cause cloudiness, and gabapentin is a commonly used medication that certainly can cause brain fog. For individuals that are told that's as a side effect, you'll hear a lot more about it. The other medication that I found that's kind of maybe an issue that gets prescribed a lot is Pamelor, nortriptyline or amitriptyline, that paradoxically, even though they're used for sedation and sleep, can also cause kind of that cloudy sensation. And a lot of people recommend that for sleeping problems that people have after a concussion. And sometimes the medicines and their side effects from the medications can be more important than the initial insult itself. So those are things to look at in the medical record when you're having these symptoms, and I'm going to call it delayed recovery as well, that don't quite fit. So mechanisms. Why do we have these kinds of problems? Okay. Now, I didn't list it here, but with Alzheimer's, even there we talk about, some of the pathology in terms of what I call brain sand, some of the synaptic, um, the kind of the inflammation around the synapses. The problem is it doesn't always correlate with there's not a certain location in the brain that if you have a problem, it manifests itself with either memory or attention, etc. When an individual has a stroke, you can pretty much predict where people will have problems. with when we're talking about these kinds of problems, it's really kind of hard to predict. So there's not really a correlation between symptoms and pathology. And unfortunately, when we're talking about mechanisms, when you hear about what a lot of people talk about, oh, we found virus in the brain that might be responsible for it. Oh, we found inflammation in the brain. We found structural changes in the brain. Guess how they found those changes? Histology at autopsy. May not be as relevant for the individual coming into the office that never was admitted to the hospital, had a severe infection with dissemination of virus all over the place. So that's something to consider. One of the things that's kind of interesting is neuroplasticity, which kind of refers to how does the brain reorganize. So let's say we have a stroke. Let's say we have a concussion. The brain has to kind of still work. Now, the conventional wisdom is that, we don't get new brain cells. It's more of an issue of using what we have left rather than making new ones. That may or may not be the same, and I have to admit I'm a little bit old and I'm not up in current on most of this, but in general, in the central nervous system, we don't grow new cells, but we use what we have. And that's kind of a way to look at neuroplasticity in terms of how to reorganize and get the information. And there's something called functional MRI, where it kind of is a surrogate to kind of measure that. And with functional MRI, what they look at is uptake of sugar or different things that are attached to molecules that get processed in the brain. And if there's if there's less uptake in certain areas or more uptake in certain areas that we believe are responsible for certain actions like thinking, memory, processing information, we think, we ask them a question, we do the study, we ask them to raise their arm, there's increased uptake in a certain area, we assume that that area is related to that. They looked at people that had all of these symptoms like brain fog, etc., and they didn't find any structural differences. They didn't find any differences. What they did find was something called connectivity differences. And particularly in the temporal lobe, and the temporal lobe is typically used for memory. The hippocampus is in there, that's short-term memory, but there's a lot more that goes on than just that. But one of the things that was interesting is the temporal lobe had a little bit decreased uptake compared to other areas. And so what they talk about is certain areas, like let's say I have to lift up my arm, even though there might be one area that's responsible for it, there's other areas that are involved with that will also have increased uptake. And that's kind of expected. But when they're talking about connectivity differences, different regions of the brain were active and other regions that typically were active at that time were less active. Now, it's hard to draw any conclusions from that, but that's the only difference that kind of fit with some of the issues that people had. Now, the problem is the controls that they had were individuals that weren't having any of these problems. So it'd be kind of interesting to see if there's individuals that are just kind of normally experiencing the memory issues or whatever, without relating it to COVID or a concussion or anything else that we don't think are on their pathway to dementia, if there's a difference. And people have, a lot was made about finding COVID in the brain, and there might be explanations for this. There's also an issue with dopamine in terms of in the substantia nigra, the substantia nigra, which produces the dopamine, very much implicated in Parkinson's disease. So, it's one of those things where with Parkinson's disease, you have tremors, you have depression. There are some, a lot of these word finding difficulties, difficulty processing. But once again, it's all histology. The one big thing that people talk about is fatigue and stress, but that's also very subjective, very difficult to measure. We have surrogate like cortisol, but not perfect. And the other one issue is also in terms of structural changes in the brain where they find neurofibrillary tangles or something like that. But once again, they're autopsy findings. Hard to jump to conclusions from that, and not very useful in the clinical outpatient setting that we're talking about. Nocebo, which is one of the things that Diane kind of mentioned, she didn't use the word, but this is exactly what she was talking about. And that's, when we think of a placebo, we think, okay, we need to figure out if something's going to work well for us or do something positive. So what we do is we give something that's inert or doesn't necessarily supposed to do anything, even though we find out that sometimes it isn't, and we look to see if there's an effect. And typically there is an effect, sometimes up to 50% of whatever effect we're looking at. But then we look at an agent or a drug or an intervention to see if there's a bigger effect. So if there's a bigger effect by doing the intervention or the medication than there is by doing what's supposed to be nothing, then we think that drug is effective or that intervention is effective. Now, nocebo is kind of a different concept in terms of we're doing stuff prophylactically, meaning we're educating people. Everyone is aware of dementia now. Everyone is aware of long COVID. Everyone is aware of a concussion and the damages that can happen from a head injury, how you need to be careful and be wary and protect yourself. Part of the problem is there's increased awareness now. We're so insightful about these symptoms. And you tie that in with the pre-existing anxiety, you have somebody that has had an event that has a major impact on them, either bumping their head without a concussion or COVID illness without a severe respiratory infection requiring hospitalization or medication, but they're experiencing these symptoms now. And before we kind of took them for granted. Oh, I forgot my keys. Oh, I left them there. But now when I forget my keys, is that related to the COVID? Is that related to the concussion? And my personal experience has been is that people come in experiencing these symptoms and don't really want to know, Doc, am I okay? Why am I experiencing? They're saying, I have I have long COVID. I have a concussion. What are you going to do for me? I can't do X. I can't do Y because of these things. And as the initial clinician, I'm thinking, okay, what interventions can I do? How do I educate this person without dismissing their concerns or their symptoms? And that is very, very difficult, particularly in the workers' compensation system. And especially with, the one big thing that this takes is time. This is very nuanced discussion because we're not saying it's all in your head, you're making this up, you're a hypochondriac. We're saying, yes, you're experiencing these symptoms, but they're likely not any different than what they were before this happened. But Doc, you didn't know me before this happened. How do I respond to that? And those are the challenges that we have, and that's what makes it difficult. And as Diane also alluded to, what does this mean for the future? Am I going to get worse? If I'm already on the road to dementia, is this going to aggravate that? Is this going to accelerate that? These are some of the concerns. And how do I address this? What I do is I like to talk about what you can do, what's not happening that I would expect to see. And hopefully that kind of addresses in terms of, yes, okay, things are not as bad. Here's what's happening. And then you ask and find out what else is going on in their lives. And in the workers' compensation system, people don't like to have, individuals to dig down too deeply into what's going on. So that's another issue that needs to be navigated. And that's what makes it kind of difficult. But this to me is probably one of the biggest things that we face, because when we're talking about brain fog in the setting that I'm talking about, it's not necessarily a severe condition. It's not necessarily impairing or impacting people significantly when they think about it. And the issue is, what can they do or can't do at work, etc. And does it get kind of compounded into other things that are going on in the situation? We talk about the workplace, etc., that make a difference. Are there financial difficulties that they're experiencing? And that usually tends to be a huge one that causes stress and causes these kinds of problems. And I think we can all kind of relate at some point in our life. So, as someone who's not an expert, What can the primary treating physician do? The people that typically have to handle this and navigate it. Practically, what I think one of the biggest things is insomnia, lack of sleep. Now, before becoming too familiar with this, I'm a very conservative person. I do not like medications. I want people to do things naturally. I mean, I want them to behave well. I want them to make sure they're sleeping in bed, not reading, not watching TV, not drinking alcohol, not drinking caffeine in the afternoon, not exercising too late at night, not eating too much at night, not drinking alcohol. But, that requires behavior, that requires time. And a lot of times it's too much of a luxury. And especially when someone has this kind of anxiety, they need to have stuff done for them. So I tend to be a little bit more liberal with the medications. Now, I like something called cyclobenzaprine, which you might see. It's a muscle relaxant. And for us Californians, it's in the medical treatment utilization schedule. It's in the drug list formulary. It's not an exempt drug. It's typically indicated for muscle spasms. But that's not what I use it for. I use it to help people go to sleep because it's a relatively mild sedative. Remember I talked about the tricyclic antidepressants, nortriptyline and Pamelor before. You'll see those used quite often. Those medications are used to treat nerve pain. They're used at kind of in high doses to treat depression, but we kind of also use it for anxiety, etc. And it's supported for those uses in the treatment schedule. The problem is they're kind of strong drugs. Cyclobenzaprine's a mild drug. It's not truly a muscle relaxant because there's not really any drugs out there that really relax the muscles per se. So what it does is it makes people sleepy. And at a low dose, it makes people sleepy without too much of a hangover in the morning, which is what we're trying to avoid in individuals that are already complaining about brain fog. Gabapentin, nortriptyline, and amitriptyline can cause that kind of brain fog in the morning or that hangover. So we're trying to avoid that. Two issues with insomnia. Is it difficulty getting to sleep or difficulty staying asleep? And so for individuals that don't have trouble going to sleep, why do you want to give them a pill to help them go to sleep? You don't need to necessarily. But when they wake up early and they're just staring, ruminating, thinking all that stuff we do when we can't sleep and we're anxious about stuff, maybe taking a pill at that time, and I recommend a very low dose. I actually kind of split the pill in half and have them take it. And then if they wake up again, have them take it again. And that's been somewhat effective. I mean, I don't have a huge sample size, but it seems like a practical approach that may work and help people. Anxiety, the elephant that's not really an elephant. Yeah, the elephant in the room. Do we want to do an early intervention or do we want to wait? And there's pluses and minuses to both. Medications in general are probably not the best way to go. I think that sleep helps contribute to the control of anxiety. So I kind of like the Scalaxin. There's other drugs out there like Cymbalta you might see in the medical records. The tricyclic antidepressants can also be used for this. The ones I'd like to stay away from just because I'm not as familiar with them, and I know they're very effective, but in terms of tapering people off or weaning them, or the benzodiazepines, the short-acting ones like Xanax, that can make a difference. But in short doses, they can be very effective. The problem is how do you taper them off, and that typically requires someone very familiar with it. Now, I talked about counseling earlier, and I'm kind of put this to being a little bit facetious. Intervention does not equal validation, and I said twice. So there's two kinds of validation that I'm talking about when you refer to counseling or refer to a psychologist. There's the validation testing that I talked about. When the red flags are going off, nothing seems to make sense. They're able to do lots of things outside of their vocation, but when it comes to work, they're having all sorts of problems. They know if their disability or their claim has been accepted on file. They know how to communicate with the attorney. They know how to communicate about when things are going wrong. But at work, they're having all sorts of problems. That might be a situation where you want to do a little bit of forensic work and get validation testing, and it might be worth paying the money up front. The other kind of validation is acknowledging and having a lot of empathy for these individuals, but not doing anything to help them get better. And one of the issues that I've kind of seen, I do a lot of utilization review, record review, and one of the things is I don't see a lot of things that move the needle. The treaters recognize the problem, they acknowledge the problem these have, and what you get is a report card. And then you get, this is what this patient was instructed on. But you don't find out, was it effective for them? Is it helping them get back to work? Is it helping them to resume function? Is it helping them with the challenges that they're having? And if it's not, are they doing it correctly? If they're doing it correctly, is there something else we can do? But a lot of times,
Hey,
and you've seen
doctor,
this, good?
we have a question for you, talking
Sure,
about sleep. So
sure.
someone is asking you to explain sleep hygiene and what it means.
Okay. So sleep hygiene basically is something where there's a lot of behavioral components, meaning these people have to prepare themselves to sleep. You want to have the proper pillow. You want to make sure that you use the bed for sleeping. You don't want to use it for working. You want to be in that place to sleep. You don't want to drink alcohol at night because it interferes with sleep. You don't want to be watching TV in bed because that also interferes with sleep. You don't want to drink caffeine products in the afternoon or late because caffeine can also interfere with sleep. You don't want to exercise too late in the evening because that can sometimes get your adrenaline going or the cortisol, and that can also interfere with sleep. And, none of these are hard and fast rules. We're all different, but these are some of the typical things that we think of. One of the things I didn't really mention that's also kind of related, that's obviously very important is obstructive sleep apnea, snoring that's related to kind of obesity and those kinds of things. And that can play a huge role in this as well. But that's not really a sleep hygiene issue. It's an intervention issue that may or may not be related to the injury. But a lot of us see it as kind of an add-on. The issue is whether it's an impactful add-on or not, and addressing it will make a difference for that individual in terms of their recovery. So that's what we're talking about in terms of sleep hygiene. It's the behavioral factors that kind of make the bed a place to sleep and doing everything that you can behaviorally to make sure that you can sleep. And, I didn't give you an exhaustive list. Can you just reply in the chat whether that answered your question or not? Okay. So, I'll,
Doctor, I think you did answer their question. I
okay,
was
perfect.
just waiting for a reply.
Okay,
Yes,
perfect.
okay, he just typed it in and said yes.
Awesome. So the next intervention is something that we hear commonly referred to as cognitive behavioral therapy, and it's basically about meditation, breathing techniques, redirection, and I'm kind of simplifying it, but it's really about giving people alternative tools to address some of the things that they're experiencing, reframing. When we're talking about anxiety, a lot of people, think that the world's going to end for XYZ. I'm going to get dementia because of this. And it's kind of like going to reframing it, breathing, which is one of the most important things I've found to try to tell people to do in terms of addressing it. Catch your breath, think about things. And they give, there's other tools like I talked about conflict resolution. Sometimes there's anxiety about returning to work. And if I'm not 100% of my best at work, what can we do? Work restrictions. This is one of the toughest ones in terms of how do you introduce someone back into the workplace where they're concerned about their performance. They don't want to be perceived as a poor performer, but at the same time, they're having these symptoms. And we know that the best thing you can do for most people, for most conditions, is get back on the horse, get back to work, do things, navigate. So if you have a good speech therapist or a psychologist, helping people navigate some of the things they're experiencing at work, perceptions where they think that everybody's looking at them funny because they have work restrictions, when in fact, no one really cares. They're just focused on their work. But those are the things you have to address, and you'd be shocked at how sometimes the realization of those problems can make a huge difference. So these are some of the things that the PTP can do. Now, I talked about this early, it takes time. And as you can tell, most of us don't have the luxury of that time to spend with people and dive in. And that's where the counseling, and hopefully we can get somebody else who does that as well. But a lot of times when it's a first line provider, that's probably the best thing to do. But there's a lot of disincentives for clinicians to do this based upon their schedule, based upon reimbursement, etc. Now, what are the things that we know are effective? Exercise, cognitive behavioral therapy, and stress reduction activities. All of these things are intertwined. There's some medications that they, haven't been proven to be effective, but we try anyway. Magnesium, omega-3 fatty acids. Magnesium is important in cellular recovery in terms of transmitting signals, etc. Omega-3 fatty acids are important as lipids in terms of rebuilding the central nervous system, which is made up of lipids. It's something called myelin, which helps signals translate from the brain to the other nerves and move muscles and involved in cognition. But the problem with these interventions is they're not serious interventions. They're not a drug. They're not a procedure. I don't need a doctor to tell me to do that. And that's, one of the things you encounter in terms of whether you're taking these symptoms seriously. Well, I'm coming to the end of my talk. Hopefully there's going to be an opportunity for questions that people have for me, and I can kind of hopefully dive into things that are specific that I did not address. But these are the options. We've done our psychology. We've done the best we can to educate. We've done the best to reintegrate this person into the system. And we've done all we can. What's next? MMI. And this is typically the section that you're going to see that's used to kind of address this if people have persistent symptoms that, that they feel are rateable. And, there are other sections that I think actually are a little bit more applicable, but much less easy to define and describe, whereas this is a little bit simpler, and I think this is what you will typically see. Obviously, I don't rate these that often. It's typically gone to a psychologist or a psychiatrist, but that's kind of where we typically end up when we've done everything we can to make this person better, and we can't do any more, and they're not going to get any better. I'm opening the floor to questions, and hopefully this was useful. And thank you for attending.
Doctor, I think it was
Yeah,
very, very helpful. There was a lot of information that you provided. We'll leave it open for just a moment. I'm going to
yeah,
do a little bit of housekeeping while we're waiting to see if we have any other questions come in.
sure.
So I just want to tell those of you who live in the Orange County area down in Southern California, we do have a Macro Pro and Friends in-person conference. It's free to you, and it is in Orange County on the 26th at Dave and Buster's. We have 6 outstanding speakers, and the entire lunch, breakfast, the whole thing is provided to you by the sponsors. So please sign up for that if you're in the area. I also want to tell you that we have some really great webinars coming up right here this week. So we just had Doctor, so thank you, Doctor. It was outstanding. We also have the cutting edge of orthopedic treatment and surgeries. We're really, really fortunate to have the Dr. Ding come and talk to us. And then in addition to that, we have upper limb prosthetics. And Dave Anderson is going to come and speak to us about that. These are really interesting topics. So I certainly hope that you go to the Macro Pro YouTube, go to the Macro Pro website and check them out. And again, the YouTube channel has all of our past programming, so you're welcome to look at that. We do not provide credits when it's watched on YouTube, but when you're on with us live, we do. So, Doctor, I have
Mm-hmm.
several people that have said,
Okay.
thank you so much. Awesome information and a great
Okay.
speaker.
Oh,
No,
good.
it's just great presentation. Thank you. But I have no questions. So
Okay.
it just people going on telling us how great you are, and you have been really fabulous. And we want to thank you so much for being part of today's program.
Thank you very much, Dan, for including me. I appreciate the support and all that it takes to put one of these on. I had no idea how much goes into it, and thank you very much for that. Appreciate
You're welcome. It looks easy. It does look very easy, but you're
it.
right. There's a lot of work that happens. All right, everybody. We'll see you at the next Macro Pro and Friends webinar, and that will be tomorrow morning at noon, at 10 o'clock. So we'll see you then. Bye bye now.
Thank you, Diane. Bye. Are we
You're
talking about it? Okay. Should I leave?
We'll leave, but I'll give you a jingle.